In the sequence of vagotomy and entrectomy, the vagotomy is typically performed first to allow for use of the stomach to aid in retraction to reach the esophageal hiatus. Through an upper midline incision, the triangular ligament of the left lobe of the liver is taken down, and the phrenoesophageal ligament overlying the gastroesophageal junction is opened to reveal the hiatus, exposing both the left and the right crus of the diaphragm. The anterior vagus is carefully exposed and dissected off the distal esophagus for at least 2 to 5 centimeters. The vagus is then clipped proximally and distally, and the segment of vagus between the clips is excised and sent to pathology for immediate confirmation. Exposure and identification of the posterior vagus is often much more difficult. However, it can be palpated behind the esophagus as a guitar string. The posterior vagus is bluntly dissected off the esophagus, and a Penrose drain is passed around the esophagus, allowing for lateral and inferior retraction of the gastroesophageal junction. A vessel loop is then passed around the posterior vagus and used to aid in medial retraction. Once again, the vagus is clipped proximally and distally, and the segment of vagus between the two clips is excised and sent to pathology. Once the vagotomy is complete, the surgeon's attention turns to the entrectomy portion of the procedure. Prior to division of the stomach, the surgeon should ensure that the proximal duodenum is not excessively scarred so as to prevent safe duodenal transection. After mobilization of the gastrocolic ligament off the greater curve of the stomach, the lesser sac is entered and the site of gastric resection is identified. This is typically located at the incisura angularis. The lesser omentum is also mobilized off the lesser curve of the stomach, ensuring that the right gastric artery is identified and ligated, and a linear stapler with an appropriate bowel load is used to transect the stomach. The posterior attachments of the stomach to the pancreas are taken down with an energy device, and the stomach is mobilized anteriorly. The plane beneath the proximal duodenum is dissected free to just beyond the pylorus and transected here with a linear stapler.